Okay, so we'll start off with the next section, which is entitled Destigmatizing Opioid Use Disorder. Learning objectives for this section include describe the impact of stigma on patients with opioid use disorder and to communicate effectively through the use of non-stigmatizing language when dealing with sensitive or discrete issues.
Juno, I think the slides, they're not showing up.
Oh, really?
Yeah.
Huh? Can you see it?
Yep, now it's working.
All right. Okay, you see the slides?
Yep, that's good.
Okay. Okay, so we'll start off with another short video. This is entitled The Opioid Chapter, Sean.
I just think providing people with an opportunity to change, and never giving up on them. It's a second chance for people, not to judge them too harshly, if you had known me, 7, 8 years ago, you would not recognize me, I was one of those people, one of those scary drug addicts on the streets. Sean Leblanc, I'm a peer outreach support worker with Ottawa Inner City Health. So I left home at 13. I faced some sexual abuse in one of the emergency services that I had to access because I was basically homeless at the time. But I got through that and I got some housing and worked basically through high school. Came back east because my grandparents, who I'm very close with at the time, got sick and enrolled in school. Things were going really great. I got some work, DJ both on radio and in clubs, and doing well in school. And I met a lady and we became very close. She became pregnant and lost the child at 7 months within her pregnancy. And I really went off the deep end with that. I didn't want to feel, per se, or I didn't want to hurt. I started drinking, but I found that didn't work too well for me because I was getting so sick and everything. A quote-unquote friend turned me on to some opiates, some Dilaudid one night, and that was basically the winner there. Living in a crappy rooming house and, being broke by the second day of the month, and I was getting really fed up with it. I wasn't happy, and then my best buddy died of a fentanyl overdose. He was 37 years old, and that really wiped me out. I just knew that I didn't want to end up like him. I tell people sick and tired of being sick and tired. I want to make some changes in my life, and slowly but surely I did. People deserve to be housed regardless of their addiction or substance abuse or mental health illness. It's basically the first step as far as I'm concerned. It wasn't until I got housing where I was actually able to make positive changes in my life. It's just nice to belong somewhere and not, having somebody wish you out of the neighborhood. It's just nice to be a part of the community, People take for granted, just the ability to lock their doors or go down and lie down and, on a Saturday afternoon or read a book and have a cup of tea. These are all things you can't do in a shelter. How I wake up every day now, happy, and it's a modest living, but it's one that I really love a lot. I used to wake up and wish I could go back to sleep because just facing the miseries of the day were always so rough and everything. But now I wake up beside, someone that I really love in a cute little apartment, just blocks from my work and a place where a lot of change is happening and everything. And it really empowers me. It really inspires me, actually. I really saw that there was a need for a voice for people with experience in drug use. So I founded a nonprofit myself called DUAL, the Drug Users Advocacy League. And we just started having meetings, organizing from there, and just basically wanted to say in things specifically that were going to affect our future. Like any marginalized group, we want to say in decisions that are going to affect us. I was able to mesh the advocacy I was doing with my recovery. It was like the more I recovered from my addiction, the more I was able to advocate for my population, and then the more that I advocated, I was able to recover more. So it really kind of went hand in hand with each other. Making someone's day just a little bit better can sometimes be the impetus for great change, you know, and I feel a great responsibility and take it very seriously. It's really emotional work, but I wouldn't have it any other way. It's just amazing how resilient people can be, and I just think everybody deserves a second chance.
Okay, so we'll start with stigma. So what is stigma? It's a negative attitude towards others who are quote unquote different. It can be real or imagined and manifests as bias, stereotyping, distrust, fear, avoidance. And as we may or may not know, people who use drugs are the most marginalized and discriminated against population. So this is just a diagram of a stigma cycle, which involves stigma, prejudice, and discrimination. So there are different types of stigma that we may encounter. There is public stigma. So again, those are stigma attributed from the public, public perception. Self-stigma, which is often stigma from a person's own stigma. So a person may stigmatize themselves because they have a substance use disorder. Courtesy association stigma. So this is stigma that involves experiencing stigma, being associated or helping people or populations that have stigma. So an example for that would be you yourself may experience stigma if you decide to open up a pharmacy that's servicing opioid agonist treatment. So you may experience stigma for trying to provide that service to that specific population. And then there's also structural stigma, which is stigma that is from a societal level. Examples may be residential treatment programs or programs that exclude patients who are on opioid agonist treatment therapy. So they have a policy that they won't allow anybody to use the residential program if they're already on methadone or buprenorphine. So why does stigma exist? There are many reasons. Some include fear, social interactions, assigning blame, the perception of prognosis, the feeling that addiction is incurable. These people are dangerous. They don't want to be associated with these people, and the person lacks willpower to help with their use disorder. Who stigmatizes? So the stigma can come from many different people and services. They include the spouse, family, friends, media, employers, healthcare providers, law enforcement, landlords, schools. So I mean, the short answer is everybody can potentially stigmatize. But I guess for us specifically, it's important to note that you will experience a lot of stigma through other healthcare providers. So again, depending on where you work, if you work in a community pharmacy or if you work in a hospital setting, you may experience stigma from other healthcare workers, and it's not uncommon. And surprisingly, even here at CAMH, you do experience a lot of stigma from other healthcare providers when you're specifically dealing with patients with opioid or substance use disorders. So factors contributing to stigma, presence of illness-related behavior, media portrayals, and knowledge gaps regarding nature and outcome of treatment. So what are some of the effects of stigma? Stigma can lead to the lack of access to appropriate medical care, housing, and employment. It may result in patients avoiding seeking help, which can result in their own increased social isolation and worsening of their own conditions. Could lead to other medical and social problems and potentially increase in risky behavior. So stigmatized individuals are often excluded from rules which apply to quote unquote normal people. Examples include insurance companies may refuse to pay for specific medications or treatment services. Patients may be charged higher copays or deductibles. In terms of stigma concerns, it's important to note that families contribute the most significant effect. They may face multiple forms of discrimination at the same time. And also self-stigma is also a major contributing factor. And all of these different types of stigmas may help create barriers to accessing services, and eventually people may stop accessing or seeking help for their medical conditions. So specific to addiction and use disorder, stigma is the meanest and the most difficult aspect of addiction. Often people are heard stating addiction is a character flaw, weakness, which can't be cured. There's a lot of social and legal discrimination with regards to substance use disorders, and this continues despite scientific evidence that addiction and use disorders are curable and treatable. So what are some of the causes of concurrent disorders? We know that obviously when a person has an alcohol or substance use disorder, they're using that to cope with symptoms of mental health disorder. Substance use leads to situations that can often make mental health issues more likely, prevalent, and worse. And some severe chronic mental health disorders may make a person more sensitive to the effects of substance. In terms of mental health issues, we know that mental health affects all ages, education, income levels, jobs, religion, and culture. Up to 1 in 5 or 20% of Canadians experience mental health illness annually. 70% of the mental health problems have their onset during childhood or adolescence, and mental illness is a leading cause of disability in Canada. In terms of mental health and substance use, people within the age group of 15 to 24 are more likely to experience mental illness and or substance use disorders than any other age group. And it's interesting to note that men have a higher rate of addiction versus women, while women have a higher rate of mood and anxiety disorders. Up to 20% of people with mental illness have a co-occurring substance use problem. And up to greater than 15% of people with a substance use problem have a co-occurring mental illness. So the prevalence of concurrent disorder is significant. So whenever you're, again, we talked about whenever you're dealing with a person with substance use issues, it's also very important to take into consideration that they may be experiencing some concurrent illness also. People with mental illness and addictions are more likely to die prematurely than the general population, and the disease burden of mental illness and addiction in Ontario is 1.5 times higher than all cancers put together and more than 7 times that of all infectious. So what are some of the effects of concurrent disorders? So often if patient is experiencing concurrent disorders, they're having worsening psychiatric symptoms and worsening substance use symptoms and disorders. They're at a higher chance of not following through with their appropriate treatment, greater risk of disruptive behavior, potentially increased suicidal ideation and thoughts. So again, reiterating what we stated already is that it's important to identify and treat both concurrently. So responding to somebody with concurrent disorders, if we're able to treat both at the same time, there's a better chance of a quicker, fuller recovery. It's important to have frequent contact, so you may need to follow up with these patients more frequently. Doesn't have to be as long, but brief contact is still helpful. Offering help with practical problems, and it's important to listen without judgment. So who wears the label? We know that many famous actors, people in the media, actors, athletes experience substance and mental health issues. And this is just a small list of people who have issues with substance use and or mental illness. So let's talk about the language of addiction. So there are often stigmatizing words, and these type of words discourage, isolate, misinform, shame, and embarrass, specifically in the use of substance use disorder. So we want to replace these stigmatizing words with positive language, which can inform, encourage, and support patients. So words can wound. So these are just an example of some words that you may hear in your own practice, coming from other colleagues or patients. And these are just some stigmatizing words you may hear. So we'll talk about specific words and words to avoid and words that we can use to replace. So one word to avoid is abuse. So this word feeds into stigma, denies it's a medical condition, and blames the illness on the individual. So rather than saying somebody is abusing their alcohol or abusing their opioids, we could describe them as having a alcohol use disorder or an opioid use disorder. Addict, abuser, junkie. Again, these are words that you probably have heard and may even hear the patients describing themselves with these terms. Ideally, we want to avoid using these terms. This will these terms label a person by their illness and implies permanency. So again, as an alternative, we want to use the same type of language with such as person with active substance use disorders. So whether that be opioids, alcohol, or polysubstance use disorder, or we could say that the person is experiencing a drug or alcohol problem. So this is a big topic that you've probably may or may not have heard about, but in terms of using words to describe urine screens. So again, we know that if a patient has a use disorder, they're often going to have urine screens, and these are often described as clean or dirty with respect to having substances found in those. So if a urine has no substances, it would be described as clean, versus if a person is on opioids and their urine shows up positive for cocaine, they would be described as having a dirty urine. So these words are to be avoided because it associates addiction with filth. So then the alternative would be if a urine has no substances found, it would be negative, and if there are substances found within the urine, it would be described as a positive. So clean and dirty versus negative and positive urines. Again, another word to avoid would be habit or drug habit. It denies the medical nature and implies a lack of willpower to stop. And the preferred terms would be the same as we've discussed, which would be substance use disorder. Or we could describe it as substance use disorder with active or inactive or in remission. Another word to avoid would be replacement or substitution therapy. It implies that methadone and or buprenorphine are the equivalent of street opioids. It suggests a lateral move, illegal to legal addiction. So again, the term we would like to use instead of that would be opioid agonist treatment. Another word to avoid would be user. So this labels a person by their own behavior, and it's associated with risky misuse. Preferred term would be person who uses alcohol or substances. So words that do work, and one word would be addiction. So addiction describes a chronic relapsing brain disease defined by a physical and psychological dependence on drugs, alcohol, or a behavior which a person will pursue despite putting themselves or others in harm's way. Addiction survivor or in remission. It's in line with other life-threatening diseases, and it's a positive indication of a person's disease status, so less stigmatizing than recovering addict. So in practice, when would we use something like this? Let's say if there's a patient who has a history of alcohol use disorder and has been abstinent for X amount of time, like 10 years, we could describe them as a history of alcohol use disorder in remission. And same idea with opioids. If they are stable on their opioids, they're on opioid agonist treatment, you can describe them as opioid use disorder in remission. Opioid agonist treatment is the practical, accurate, and non-stigmatizing term to describe addiction treatment with medically monitored medications, specifically methadone and buprenorphine. And a patient, rather than, again, an addict or a user, it's similar to other illnesses, accurately refers to a person who is being treated for an active addictive disorder and replaces a stigmatizing label like addict. And remission, which is a medical terminology to describe a time when signs and symptoms of the illness have disappeared, and it emphasizes that addiction is a medical condition. So we'll just go over this case study very quickly. This is SP, who is a 32-year-old male. During a meds check, the patient mentions that he moved from Manitoba 1 year ago. He's currently living alone. His dog recently died. He's having problems sleeping, and he doesn't enjoy walking to the park and has more aches and pains than usual. So we look at his current medication list, and we can see that he's taking levothyroxine 50 micrograms per day, long-acting morphine 15 milligrams twice a day, short-acting morphine 5 milligrams 4 times a day when needed. To note, he was previously only taking 1 or 2 tablets per day, but now he says he's taking the full 4 tablets per day. And then he's also prescribed clonazepam 0.5 milligrams twice a day as needed. And he states that he takes the full 2 tablets, so 1 milligram of clonazepam per day. So what are things to consider with SP? So let's look at his chronic, his pain medications. So going back, we can see that he's on long-acting morphine and short-acting morphine. So we want to look into this and see, first of all, why is he taking these medications? Is it indicated for appropriately? So number one, we know that a lot of times the medications for opioid medications may not be prescribed for appropriate indications. So we want to make sure if it's prescribed for an appropriate indication, and if it is it for an acute injury or is it a chronic injury? We know in terms of his socio status that he had a recent move and he has little family or friends in his new location, so he may be socially isolated. He's had recent loss of his dog. So again, that's a traumatic event in his life. So we may be considering he may be suffering from signs and symptoms of depression. And with that, you know, again, we talked about if there's substance use disorder, concurrent disorders, is he using morphine and clonazepam to self-medicate for undiagnosed depression possibly? So as the pharmacist here, there are things, you know, you can discuss with the patient specifically with SP. Number one, you're concerned about his increased use of his morphine and his clonazepam. You know that there's a potential for a use disorder and dependence with both these medications, and also combining both these medications, combining two CNS depressants, there is a higher risk of opioid overdose. In terms of his concurrent disorders, you know that you know, he may or may not be experiencing depression or anxiety. So again, you can refer him to your family doctor or psychiatrist for an appropriate evaluation and assessment and diagnosis if necessary. And again, if those are diagnosed, then recommending appropriate treatments and pharmacotherapy. Again, you can always offer to contact the physician or psychiatrist to provide them with information, and then offer to follow up with the patient in a few weeks. So in terms of fighting against stigma, we know that drug use is first and foremost a health issue. Criminalization of drug use undermines public health efforts, and people with lived experiences know best what works in their own communities. We know that everybody has the right to be involved in decisions affecting their own lives. There's a shared responsibility between the public and the healthcare providers, and there needs to be a comprehensive long-term process. It's important to reduce discrimination and have culturally appropriate services, and make sure that all the research and treatments that are available are being continually evaluated so that they are appropriate for the time. So how can you help end stigma? Be aware of your own attitudes and judgment. Always imagine walking in their shoes, and it's important to always focus on the positive. And when you're dealing with patients, to treat each patient with dignity and respect. And finally, what you can do is speak up with stigma when you come across it in your own personal life or professional life with your family, friends, and colleagues. So to make a difference, know the facts, be aware of your attitudes and behaviors, choose your words carefully, focus on the positive, pass on facts and positive attitude, treat people with dignity and respect, and make sure to include everybody. Okay, so that's the end of the second section.